who didn't do as well as you would like to. If you'd like to discuss your exam with me, that's perfectly fine, we can do that. One administrative note, I told you guys, the branches off of the ascending aorta are the coronary arteries. But it's a fine point, it's a point well taken by me, so I'm going to give dual credit for the branches off the arch of the aorta and the branches and the correct answer, I should say, all right? So that will be dual credit, so some of your grades will change, about half of your grades will change. All right, so there you go. All right, I mean, it's fair point that's taken, you know, if it's such a high miss, it clearly it did not land. And it is, I want you to, it's important surgical anatomy. Like that is where you're gonna hear questions like that when you're in surgery or getting pimped by surgeons, okay? So just understand it's seemingly minute test-taking skill, but it actually is a fairly major anatomical point. So anyway, now everybody knows that, we'll all remember, okay? So anybody who wants to come see me about their exam, let me know. I'll stick around after. We can make appointments or whatever. We can do it after because I have nothing left, and I think you do either. So with that, for today, we're going to do a lot of anatomy. So what is this, what is that, what is this? It's pretty straightforward, okay? Only going to do about 48 slides, 50 slides, and we're going to get you guys out of here because I'm sure you're all focusing on anatomy and physiology 1 now, and then biochemistry subsequent to that. We'll think about anatomy and physiology 2 over Memorial Day weekend. So great, right everybody? All right. So any questions before we get started about anything? Anything you'd like to point out? Okay. Objects you'd like to throw, please try to hit the podium and not me. All right, here we go. So, circulatory system. Really what we're going to talk about a lot is the actual layers, the anatomy of the vessels themselves. Not necessarily the individual nomenclature of the vessels. Where you'll get that is when you get to the individual body systems with Mr. Wright and with me. So when we talk about the pulmonary vasculature, when we talk about the digestive system, we'll start to layer in those vessels, and he'll do the same when you talk about upper, lower limbs, thorax, and so on and so forth. So really what we're focusing on here is hemodynamics, which is somewhat complicated, but honestly, if you guys have looked forward at these slides and you've seen all the equations, I want you to understand this is not going to be a physics examination, all right? We're going to talk about what those components mean and how they interact, but as far as calculating, you know, Pucell's equation and all of those things, we're really not doing that. We just need to understand the components of what affects blood flow through a tube. Because it becomes important when we talk about different lumen size of different vessels and the different characteristics of the vessels themselves. Some are more elastic, some are more muscular, some are more stretchy, all right? And so we put all that together. So if you're looking at all these equations, like what the? Just relax, okay? And let us get there, okay? So, blood, you guys know what blood is? Good. All right, so mostly plasma, we know that, solid components, which is why it becomes a complex fluid, because it's not just a fluid. It's a fluid with solid components in it, and solid components that have deformable properties that are flowing through multiple different types of tubes at multiple different lumen sizes at multiple different pressures. So it can become a very overly complex subject. We're going to try to take it into a basic level, all right? So this right here, hematocrit, you guys will talk a lot about this kind of stuff as far as like actual blood cell lineages and the development of the, like hematopoiesis. You guys familiar with the term hematopoiesis? It's the creation of blood. All right, erythropoiesis is red blood cells, thrombopoiesis is platelets, and leukopoiesis is white blood cells. It all is occurring in the bone marrow. Where you really get into that blood cell lineage stuff is mostly going to be in clin lab. There's really going to start hammering that home as a clinical laboratory. So we're just here talking treetop basics: red blood cells, white blood cells, platelets. All right. Hematocrit is basically, it's not all the solid component, but it's the amount of red cells in your blood. So have you ever heard of an H&H, hemoglobin hematocrit, right? Hematocrit's the bottom number of that. It's basically the proportion of red cells in your blood. And why is that important? It speaks to the oxygen carrying capacity, which is what our red blood cells do, why we have them. They're the most numerous type of cell because we need to distribute oxygen all over to various tissues that are really far away when you think about it. Like everything seems close, until it has to travel the number of miles it has to travel to get there. So we need millions of red blood cells to deliver that, right? I don't know why that's crossed out. Red blood cells are by far the most abundant cell. There are millions of red blood cells, all right? They carry oxygen, so red blood cells are deformable. The hemoglobin is in a tetramer format, so 4 different things, and each one has a hemoglobin molecule, and the hemoglobin molecule attaches to the oxygen, or the oxygen attaches to the hemoglobin molecule, and that's how it delivers the oxygen to the tissue, okay? White blood cells, inflammatory processes, that's why that one's in red, because it wasn't on there before. Inflammatory processes and immune processes. So it's important for you guys to understand now, when you start to look at elevations of white blood cells, most people will associate that with infection, right? But understand that it is also a marker of inflammation. So let's say somebody has a rheumatoid arthritis or some other autoimmune disorder, some kind of inflammatory process. They will have an elevated white cell count, even though they don't have an active infection, all right? Not necessarily important here, but understanding that as you progress forward in subsequent semesters, it really helps, okay? And then platelets aren't true cells, they're fragments of cells. So a thrombocyte is a big cell that is then broken up into several little cells, little fragments of cells. And those, as you should know, I hope, are involved in clotting. And that's as much as we need to really know about the platelet stuff right now, all right? Plasma is a liquid component, carries the electrolytes, carries the oxygen, that doesn't carry the oxygen, carries the cells that carry the oxygen, all right? Proteins, also a large component of plasma proteins. We're going to talk about oncotic pressure in here. Plasma oncotic pressure. So what is oncotic pressure? In a basic term. Go ahead.
Pressure exerted in the cells or the vessel.
It's the pressure exerted by a large molecule in a fluid. All right. So oncotic pressure, let's say a big protein like albumin, which you may not know, but it's one of the largest proteins we have. So albumin creates an oncotic pressure, meaning it helps draw water to it or retain water in. So when we give somebody albumin, sometimes we're not just repleting their albumin, we're also trying to draw water into the vasculature because it's attracted to that large, huge albumin's protein molecule. Okay? So we're gonna get more to that in a little bit, all right? Other things we have, globulins, you're familiar with immunoglobulins, IGs, familiar with IGs, IgA, IgG, IgD, IgE, IgM. All right. Talk about that in immunology. And then other proteins we have, fibrinogens, things like that. So the most abundant protein we have, and the one that's really most of consequence when we discuss capillary exchange and fluid movements, is going to be albumin. Anybody know where albumin's made? Liver. Liver. So when we talk about, when we get to the digestive system, when we talk about liver function, anybody ever heard of a liver function test? All right, liver function test, people talk about, but it's really not necessarily a true test of the liver function. One of the functions of the liver is to make proteins. All right? Anyway, neither here nor there. Circulatory system, remember the very first slide, the very first presentation, we talked about body fluid components, or compartments, intracellular, extracellular, okay? Most of the fluids where? Intracellular, that's right, all right. And then why are extracellular and plasma? What is the other term for plasma? Intravascular, inside the vessels, where it really is most important. That's why that's where we're gonna spend a lot of time talking here. Interstitial fluid exchange with what is in the vasculature, all right? Most cells, and I know we know now, everybody who was paying attention before said, well, that very first slide said myocardiocytes do not have interstitial around them. They don't have interstitial fluid around them, that is true. Most cells do have interstitial fluid, which is how we go through nutrient exchange and waste exchange in the capillary exchange that we're going to get to when we get to the capillary network. All right? Enough said about that. So, if we're looking at the fluid compartments, okay, the smallest fluid compartment is plasma, and then the largest fluid compartment is an intracellular fluid, all right? So 2/3 of our fluid is intracellular, 1/3 is extracellular, and less than that, a percentage of that is intravascular. Right? Pretty much review so far. Everybody with me? Okay. Now some pure anatomy stuff. Just what is this layer of this thing? All right. Arteries, arterioles, capillaries, venules, and veins. All right. They have similar wall structures, but what the finite point is going to be is the differences in those walls. So as we're going through these next few slides, there's going to be a description of something and then a comparison chart. Description and comparison. And what I urge you to do is to study what the differences are. Not, if you're making two lists, the similarities is a very long list. The differences is a much shorter list, and that's what helps stand out one to the other. So we'll talk about the elasticity of arteries versus the collagen in veins, and so on and so forth. And hopefully that makes more sense as we proceed. Okay? But as we're going outside, so the outside of the hose to the inside, externa, right? Tunica. What does tunic mean? The covering, layer, sure, whatever, yes. Covering. So the external layer, which you're going to either see, remember, everything has to have 2 or 3 names. Externa or adventitia, and then media, middle, and then intima or interna. So they're pretty easy to remember the nomenclature as far as goes out to in. But if you look here, it's the differences in the thickness of the layers based on the function of the vessel that helps stand out, and then in the individual components within those layers. So I've highlighted them in boxes. Those are the same, whether it's an artery or a vein. But then now, the sublayers is what makes it different. So everybody, I imagine most of you know, arteries are more muscular, right? Veins tend to be more collapsible, right? Higher pressure in which vessel? Arteries. That also should help, that helps understand why they're more muscular. The walls are under more tension because of a higher systemic pressure. If you cut an artery, it spurts out. If you cut a vein, it just kind of drools out, right? So, veins, more collapsible, more distendable to a certain extent. Arteries, more stronger, firmer wall, muscular, all right? Now, usually, this is a good way to sort of remember it if you're thinking about the lumen. Everybody knows what I mean when I say the lumen of the vessel, the inside where the blood is. Lumen of veins is usually a little bit bigger than the lumen of the arteries. For a same size vessel, right? The lumen of the vein is usually larger. And it's because the arterial wall is thicker, it's taking up more space. So the actual lumen is smaller, right? Versus the vein. It's an easy kind of way to start to jump off this layer discussion that we're having, okay? So outside, externa, collagen, just tough tissue to basically contain, cover. It's a tunic, like we said. It's covering the outside of the vessel, holding it down, anchoring it to surrounding tissue as well. As remember we talked about the pericardium outside, the fibrous pericardium, continuous with the external layer of the great vessels, right? That's what we're talking about, right? This is the external layer of those vessels. Helps to anchor, just like the pericardium helps to anchor the heart in place. These help hold the vessels in place so that the arteries don't flip it around like a snake, Elastic fibers, but these are the main, I guess I'm used to this desktop. So, nervi vasorum and vasa vasorum. If you understand even basic Latin, it's exactly what it sounds like. It is the blood supply and the innervation to the vessel, okay? To the vessel itself. Because you guys know the process, vasoconstriction, vasodilation, the smooth muscle within the vessel itself. It needs to be fed, it needs to have waste products removed from it, and it needs to have some sort of neural innervation to shrink or open up, right? And this is what accomplishes that. So, this is what I was talking about. Thinner than the tunica media. Okay, so we haven't talked at all about muscle yet, right? We haven't talked about all the smooth muscle or elastic fibers or anything like that. We just talked about the collagen covering on the outside. That is thickest in veins usually. What is going to be thickest in arteries is the middle layer where all that muscle is, all right? And this is going to be a common theme. You're going to see elastic on the artery side. And you're not going to see much elastic, if any, on the vein side, all right? So think elastic on the arteries, collagen on the veins, okay? And again, veins, collapsible, but not super stretchy, right? Not super stretchy. Think about, and this is the prelude to the next few slides, but think about the force that the aorta has to absorb as the left ventricle squeezes all of the blood out, right? If it wasn't deformable and elastic and stretchy, what could potentially happen? Rupture, tear, aneurysm, right? No, but it has to have that muscle and those elastic fibers so it can absorb that and then propel the blood forward, all right? Whereas vena cava, by the time all the blood makes its way back even to the inferior vena cava, how much pressure do you think is left in the system? Not a whole lot in the vein side of the system. So it doesn't have to be really stretchy. It doesn't have to absorb forces that way. It just has to be able to collect that blood. All right, does that make sense to everybody? So again, if you look here, like I said, roughly the same size vein or roughly the same size vessel, lumen on the vein side is going to be a little bit larger, okay? Whereas lumen on the artery side is going to be a little bit smaller, and the reason for that is this thing we haven't talked about yet, which is this, keep moving, this thick muscular wall right here, okay? Because of the function of the artery itself. Anyway, now, this is what we're talking about. Tunica media, the middle. Mostly muscle, a lot of muscle in the artery, the thickest layer in the arteries in general, okay? Again, these, don't get this confused now. 1 to 2, these are the sublayers. All right, so the whole thing is the tunica media. These are the sublayers of the tunica media, okay? Remember I said elastic is going to be a theme in the arteries. That's why it's highlighted in bold. Only in the arteries do we have this elastic lamina. And what is a lamina? A layer, okay? So it's an elastic layer, elastic fibers, okay? Only in the arteries. What's going to be in the veins, what did I say? Collagen, mostly collagen. Elastic arteries, collagen veins. Just grossly bucket them that way, and you'll steer yourself right, okay? Another thing we're going to talk about more later, but here's a prelude to it, is there is no direct parasympathetic innervation in the nervi vasorum, okay? There is sympathetic stimulation only. So it is an up or a down regulation of the sympathetic nerves, and the catechool means that they release, that either dilates or constricts our veins, or vessels, excuse me. Is that clear enough? And when we get up, we're going to get all the way towards the back, and we're going to talk more deeply about autonomic regulation. But just understand, it is all sympathetic stimulation. Okay? Upregulation or downregulation, basically, of epinephrine and norepinephrine.
Sir, you said there's no direct parasympathetic.
No direct parasympathetic stimulation, right? So that nervi vasorum, where the nerves are innervating the actual vascular tissue itself, is just innervated with sympathetic nerves. Okay? So we either push more epinephrine, more norepinephrine, or we downregulate epinephrine, norepinephrine. We don't have like a contravening force where we're releasing acetylcholine parasympathetic stimulation, okay? All right, again, side by side. Tunica media, this is where, the other thing, media, muscle, however you need to remember it, right? That's where it is, tunica media. For the arteries, that's where the muscle is, that's where the elasticity really is. All right. That's what gives the arteries its ability to stretch, absorb potential energy, and then propel blood forward. As we move farther away from the heart, we're going to see less elasticity and an increased amount of muscle. All right. So just that's what that little bullet means as we move farther away from the heart. The closer our arteries, the larger arteries closest to the heart are going to be our elastic arteries, and then as we start to move farther and farther away, they're going to be called muscular arteries. Okay. And again, no elastic here. A lot of elastic here. Function. Everybody follow me so far? Yep. And there we go, tunica media. Associate M with muscle, M with middle, however you gotta do it, but that's what it is. And then again, there is smooth muscle on both sides, right? All of our vessels have smooth muscle in them. That's what allows them to vasoconstrict or vasodilate. Arteries have more, and arteries also have elastic lamina. What is a lamina? A layer. So within the muscle, we have a layer of elastic. Fair? Okay. I don't know if I put this slide in here. This is just a cross section. Not this slide, I mean this picture. It's just a cross section for you. I can send it out if you like. But the tunica interna, or the intima, intimate with the blood, the small layer inside, right? We're talking about the lumen now. What's with, facing the blood, if you will, or containing the blood. Internal elastic lamina. So we have an external and we have an internal. What does that really mean? It means in an artery, there's elastic on the outside of the middle layer and on the inside of the middle layer. Fair enough? Okay. Basement membrane, and we've seen this word before now, the endothelial layer. The endothelium, the inside. Remember me saying that the endocardium is continuous with the endothelium of the great vessels, right? That's what this is. The inside of the vessels. The inside layer of the vessel. So the inside of the heart muscle squeezes the blood out into the inside of the great vessels, and so the endocardium, endothelium. All right?
Is there a question?
Yes.
If you go back to that picture,
This one?
That one, yeah. So it says subendothelial layer there, and I'm assuming that's the same as the basement membrane layer. Which one is going to be more commonly used?
Oh, the basement membrane, the tunica,
But they are the same thing.
they are the same thing. Yeah. I told you everything has that, I'm gonna go with the nomenclature that I throw on this slide, right? So if you catch something like that, default to this, but yeah, good catch. I told everything has to have 6 names for some reason, right? All right, where are we at? Okay. Internal elastic lamina. So again, we're on the outside of the inside layer. I know it's a lot, right? But another layer of elastic. Then the basement membrane, subendothelial layer, as you pointed out. Only in arteries, right? Yeah, you guys picking that up? The elastic stuff is just in the artery side, okay? Basement membrane, it's the support layer, and then the endothelium, the true endothelium, is where we have exchange of nutrients, blood flow, things like that. So the lining of the lumen is the endothelium. Importantly, and what you're going to learn about a lot again in clinical laboratory and then hematology, are some of the local tissue factors that are produced by the cells of the endothelium. All right. Most of them have to do with clotting or local dilation or constriction. So when you start to learn the coagulation cascade, One of the ones that's not on here is literally called tissue factor. Tissue factor begins the local process of intrinsic clotting. So it begins the formation of a platelet clot. Von Willebrand factor, has anybody ever heard of von Willebrand disease? Okay, von Willebrand disease is what we call a bleeding diathesis. It's if you don't have enough von Willebrand factor, then you don't clot properly, so these people bleed a lot. A lot of times where that shows up is heavy menstrual cycles, or a lot of times where we first find it is dental procedures. These people bleed oozing type blood, like not spurting, but like it won't stop. So they're bleeding, they can't get them to stop, and then test it when they have von Willebrand disease. So it is involved in platelet factor, clotting factor 8. Tissue, TPA, that helps break up clots. Okay. Thromboxane A2, local vasoconstrictor. All right. So you might know a medicine called aspirin that inhibits thromboxane. Endothelium from the endothelium promotes vasoconstriction. And then nitric oxide. Any supplement jockeys in here? Like take supplements, gotta get your pump on. Nitric oxide blows up your veins. Everybody loves a vascular guy, right? So, yeah. Nitric oxide, no explode. You make no explode, yeah. Prostacycline, same. So vasodilators, okay? Nitric oxide has a big role in both cardiac and erectile physiology, as a matter of fact. So, other functions, so angiogenesis, you remember me talking about anastomosis? Anybody remember me talking about anastomosis? Yes. So angiogenesis, the process of creating new vessels, is how anastomoses are formed. Any questions so far? You guys hanging in there? As much as possible? All right. So, keep going. On the elastic artery train. You guys picking up what I'm putting down there? Elastic on the artery, okay? The other thing, here's a unique feature we haven't talked about yet. So the endothelium has extensions called valves in the venous side, okay? And why, and we haven't even got here yet, but let's think this through. Why would my lower leg veins have valves? To prevent backflow, exactly, to prevent backflow. Right? And what happens when those valves become incompetent? You ever heard of varicose veins? Anybody heard of varicose veins? Yep. Incompetent valves, reduced blood flow, more engorgement, the veins get big and unlooped, right? And then subsequent to that, you start to develop edema, and so on and so forth, okay? So we have valves in our veins, more so in the lower limbs than in the upper limbs, because gravity is not our friend when we talk about venous return, right? So we need to have help to get it up to a point, get it up to the next point, get it back to the heart, okay? So, tunica intima, again, here's our valves, which are just extensions of the tunica intima. Smooth muscle, flap. And then, again, on the inside here, a little bit smaller on the artery side, just based on, again, this very large media layer which has all the muscle, okay?
I have a question.
Yes, sir?
The elastic lamina, that's different from the elastic membrane, or are they the same thing?
Well, the elastic membrane is the same. It's lamina or membrane is going to be the same thing. So there's multiple, but in that case, this is the external elastic one that's on the outside of the muscular layer. The internal elastic lamina is going to be this little guy right here, the internal elastic. So membrane lamina, same thing. Okay. Good question. All right. Good? There's a picture of blood vessels in an artery for you guys. Okay. That's not actual size. mostly oxygenated. What arteries don't carry oxygenated blood? No. Can't learn stuff against your will. Alright, major arteries, elastic and muscular, we talked about already. The elastic ones are going to be closer to the heart to really absorb that flow and propel the blood forward, and then the muscular arteries are going to be a little bit farther away, alright? There isn't, as it says, there's no, like if you were to do a dissection of a large artery, there's not going to be like this clear delineation of transition where it goes from more elastic to more muscular. It just sort of gradually happens as the artery goes across. So like as we're going from the aorta, let's say the descending aorta into the iliacs, right? There's not a clear line where the aorta, which is a very large elastic artery, becomes the more muscular iliac artery. Alright. Really, the iliacs are kind of a transition between the aorta and the femoral. So, elastic arteries withstand higher pressures. Does it make sense? Right? Coming out of the heart, have a lot more pressure. Most of that systemic blood pressure is coming out right there. They have to withstand that force. And then also, what those elastic arteries do are help transition potential energy through the stretch into kinetic energy, propelling the blood forward. Yeah.
What about those same coronary arteries?
Ah.
What about the coronary arteries?
That's why they are filling in diastole,
Yeah.
right? Push the blood up, kind of just slowly trickles back down, and then fills up the coronary arteries. Otherwise they blow out. But that's why. Again, as we're blowing out, right, we have, when you get, I don't know if you saw them in the lab, we have to say that, we're talking about the aortic valve, right? So those cusps flay open as the blood is ejected from the left ventricle. Sort of helps protect them a little bit, so blood doesn't like squirt in, even though some does go in systole. But the majority, again, as it just sort of flows back down, that's when it fills. So, I know you're looking up to the left. I promise I told you that.
No, you did. And I remember it. I still got it wrong. Crazy. No, I was just wondering how elastic those would be.
Not so much, really. They're small. I mean, not so much. They're going to be more muscular than anything. I mean, they're all going to have some elasticity. But, I mean, I understand your question. The genesis of your question is, does the blood, that's why the blood just doesn't shoot into them over, during ventricular systole, or else it would overwhelm the system. You know what I mean? Plus other things, like if the ventricle's in systole, it's heart squeezing intense, that means squeezing against the coronary circulation as well, so it kind of filling in diastole has, sort of like a dual purpose. Yeah. Alright. So, here's our list. Again, like I said, the big ones that are real close. Like I said, I mentioned the iliacs. Our large iliac arteries that split off our descending aorta and then become our femoral arteries. So they're kind of like a transition artery, although they are technically elastic arteries. So these are big diameter, large lumen arteries that are really close, relatively close to the heart. And conducting arteries. So those are also called conducting arteries because they conduct the blood essentially into the muscular arteries that then further distribute it to the body. And I want to draw your attention to this point right here. So everybody's familiar with the rubber band, right? So pull the rubber band back, let it go. Potential energy becomes kinetic energy, right? So aorta accepts a big amount of volume from the left ventricle, squeeze it. Those elastic fibers stretch, then what happens? They retract because they're elastic, and that helps propel blood onward, okay? So it's not just one big squeeze from the left ventricle that sends everything around. It is also the secondary effect of that kinetic energy that's transferred into the system, right? Stored as potential, squeeze, stretch, relax, blood propels forward. Does that make sense to everybody? Yeah? Okay. And again, another reason why they have more muscular walls, why they have the external and internal elastic lamina, right? Gotta have those elastic fibers so that can happen. So, elastic artery just has, and again, like I said, when you see this, you see multiple elastic lamella, right? That's elastic layers within the major internal elastic, and where's the external? It's somewhere. So we have the internal and external elastic, basically sandwiching the tunica media, right? Some more elastic fibers, a higher percentage of elastic fibers, but again, if you were you're not going to look and cut to where it just clearly stops, where there's fewer elastic. It just is a slower gradual. So as we go aorta, iliac, then to femoral arteries, a little bit less and less and less elastic fibers if you were to look at it in cross section. Okay? Muscular arteries, less, no elastic recoil is probably a little bit too definitive. Let's say significantly less, okay? But for the purposes of our class, you can remember none if it helps. But it's not their job, all right? It's not their job to really do this elastic recoil and this kinetic. That by the time they receive the blood, the systemic pressure and the pressure behind it from the distributing arteries is continuing to push the blood forward into now what's following these smaller arteries and then the arterioles, right? So we don't need as much elastic recoil to continue to smush this blood forward and forward. We have systemic blood pressure behind it that's going to continue to do that for us, all right? And these are distributing arteries, right? So the other ones were called what kind? Elastic conductive, right? These are muscular distributing arteries. Distributing down, again, when you're in the femoral artery, you're still in a fairly large artery. The brachial artery is a large artery. The axillary artery is a big artery. But compared to the subclavian, the brachiocephalic, the aorta, smaller in diameter. And now we're going to start to branch into smaller and smaller passageways. And again, that's why we don't need that elastic recoil, because we don't have the lumen, the capacity to absorb that as we pull. So blood was continuing to be propelled with this elastic force into these smaller lumen vessels. It would cause damage, right? So again, we get the big force of the blood vessels that are closest to the heart. They move it to the smaller arteries. Now we have the musculature that's going to continue to vasoconstrict and vasodilate, move that blood forward along with the pressure behind the blood. Does that make sense to everybody? Okay. And again, just if you see here, fewer of these elastic lamella. So fewer, sorry, that's a terrible drawing. I just crossed it out. But fewer of those elastic layers, basically, okay? In the middle, still the same major ones on the outside and the inside. In the middle, fewer elastic layers, okay? You get what I'm saying? Maybe, what's up? No? You're laughing at me? No. Think you're better than me? I'm just kidding, you guys. It's Friday. Come on. All right. Any questions up to now? We are almost done. That's about as much as I'm going to put in your brains for today. Is that all right? Okay. So any questions up to now? Does everything I'm saying make sense in the way that I'm saying it? You guys get, I mean, I know first pass, again, nothing survives first pass, especially when you're thinking about A&P I and biochemistry. But I just want to make sure that the explanations are sticking a little bit. Okay. All right. So now we're going to get to arterioles, and I think that's as small as we're going to go for today. The capillaries we're going to pick up on Monday. Same layers, you see. I left this over because this is one of my favorite things. Very thin, thin, thin. Small. Okay, these are small vessels. They have thin layers. All right. These aren't these huge muscular arteries. Now, we're on the artery side. We're on the oxygenated blood flow side. We still have smooth muscle, we still have elasticity, we still have elastic fibers. But again, does it make sense that as vessels get from big to small, the walls are also smaller? Yes. That's all there is, really. I'm not trying to insult your intelligence. That's what it is. It's just as they get smaller, the walls also get smaller, right? The tunica media here, though, is very important when we talk about our arterioles. How do we really maintain systemic vascular resistance? It's here. We really maintain our systemic, the vasodilation or vasoconstriction of our arterioles is what is really the genesis of our systemic pressure, okay? Because it's a resistance to flow or it's an accommodation to flow, all right? So if the arterioles squeeze down, back pressure, blood pressure goes up. The arterioles open up, no back pressure, accommodation to flow, blood pressure can go down. So what does that mean to us? That means when you stand up and you need to perfuse your brain, everything's going to squeeze down. And what's squeezing down? These guys and the precapillary junctions that we're going to talk about. Okay? Very minute changes, but overall, if you accommodate in a, you go back. 400 million. Why do I put that number there? Who gives a shit? A lot, right? 400 million vessels squeezing down at the same time helps maintain perfusion of your brain. Does that make sense, everybody? A lot of surface area squeezing down, resisting blood flow, keeping it back into your brain where it belongs when you stand up, right? For example, resistance vessels. So again, this is just upstream, downstream, right? So artery, capillary, what's in the middle? Arterial, right? So our arterioles open up, we got a lot of blood flow, the pipe is big. Systemic pressure is lower. Squeeze the pipe down, back pressure on the system, pressure goes up. Does that concept make sense? Yeah? Okay. That's really all it is for now. Good enough. So that's why they're called the resistance vessels, because them opening and closing, yes. Oh, okay.
I was gonna say if these drive afterload.
What's that?
If these drive afterload.
These do drive afterload. I mean, they don't drive afterload, but they contribute to afterload for sure, right? Yeah. So if they're all squeezed down for whatever reason, because let's just say your renin-angiotensin aldosterone system is on 11, but these will all be clamped down, and the next thing you know, you have an increased afterload. Yeah, systemic pressure is afterload, so you're right. Does everybody, I know that middle part maybe not make sense, but does that make sense why this would contribute to afterload if they were all constricted? What is afterload? The pressure that the ventricles have to push against to get blood out. So if systemic blood pressure because of these things is increased, afterload is increased because the ventricle has to squeeze harder to get the blood out. Okay? All right, smaller now. Met arterioles. So we have the arteries, then the arterioles, and now we have met arterioles, and these are our connections with our capillaries and our capillary beds. Capillaries being the smallest blood vessels we have. 1 to 2 blood cells thick in boxcar and 3, right? So, here, I'm gonna go to this, I'm gonna go forward and I'm gonna come back, so just bear with me, right? So, this is the metarterial right here in yellow, and the big one is the arterial. So the thing at the top is the arterial, and the little connector guys right here and here are the metarterial. So very small little things, just connecting a very small vessel to a very smaller vessel, all right? So, at the junction where the arterial and the metarterial meet, it is just controlled with normal smooth muscle vasodilation, vasoconstriction. At the capillary side, so the metarterial going into the capillary, there is a pre-capillary sphincter. See that thing in the green box? And what that is a single smooth muscle that opens or closes in order to regulate blood flow. Okay? Let me go back. So, again, at this junction right here, which is before the capillary, so when you're coming from the big vessel into the smaller vessel, no real sphincter, just normal layers of the vessel. When you get to the other side, before it goes into the capillary bed, the smallest vessels, we have this circumferential smooth muscle that we call a precapillary sphincter. Okay? Go back to the picture. So we have normal blood flow here through the arterial, down the mid-arterial, and before we get into the capillary, we have this little guy right here, which is a smooth muscle that goes around and either contracts or opens to allow or disallow blood flow. Is that clear? All right. And precapillary sphincters. Let me just explain all of this right here in one shot. All of this stuff is one stupid thing. All of that. Basically, this is what happens. This is also what contributes to resistance and systemic blood pressure. If they were all closed, we have an enormous systemic back pressure. We also have no flow into the capillary, so the tissues wouldn't be getting fed. If they were all open, then we would have a loss of blood pressure, a loss of back pressure. So these are important. The takeaway is that these precapillary sphincters are also critically important in the maintenance of systemic vascular resistance. Okay? And we always talk about blood pressure and systemic vascular resistance in a bad way. That's hypertension. We need normotension. We need some resistance because we need blood flow to go up against gravity, right? So, and last but not least, for today, we always have the exception to the rule. So, what this picture represents is the arterial side and the venual side, so the artery side, the vein side. We have a mid-arterial and then going into the capillary. So this little ball in the middle represents capillary bed. Okay? There is always a thoroughfare channel that helps maintain perfusion regardless of what's happening in the precapillary sphincters. Okay? So you see that at the bottom. If all the precapillary sphincters are closed, there is still a way for tissue perfusion to occur. Yes?
Just for my simple brain, so like the thoroughfare channel is like a highway passing through a city, and then the capillary bed network is the surface roads with stoplights.
Suburbs, man. Yeah. Yeah. I would say the thoroughfare channel is like I-35, but that's a shitty analogy nowadays. But yeah. Yeah, it is. So it's a way to get blood through regardless. Okay. Yeah. Like the highway is a good way to put it. All right. Any questions you got? All right. Which one? Bravo? Bravo. That's the right answer, yep. Femoral. Femoral? However you want to say it. You kill it. Nervi vasorum. Tunica externa, that's right. What else goes in the tunica? What other thing that's like the nervi vasorum but a different word? Vasa vasorum. So the nerves and the vessels that actually innervate and feed that musculature of the vessels themselves. That is all I have for you guys today. We have more than enough time to cover all of this. I know some of you, before you have any consternation, there's only 4 blocks, there's only 4 didactic blocks for every block. The only reason it seemed like we had 5 on the last one is because there was a lab. There's no lab for this one because there's really no hemodynamic lab, but there's 4 in-person, me on the podium blocks for every single one of ours. So if you think we got short in one for block 2, we did. It's the same amount of time to cover the material. Okay, you guys? That's all I have. Congratulations. Good job today. And if you want to talk to me about your exam, I'll stick around and have a good weekend.